So the first group, group 4, group 5? Group 5, show your hands. Okay, now we have 2 topics. The first group, group 5, will be presenting the topic so-called melanoma is what? More formidable than SCC and BCC. Okay, I invite group 5 on the stage. Okay. And then group 6, show your hands, group 6. Group 6 will be the opposite party that will counteract the fact and truth that they try to presenting. Okay, group 6, where are you, group 6? Okay, please step this way so I can remember the audience. So now we have group 7 and group 8, right? So the question is, malignant melanoma is a more forbidding condition or more severe or more fatal than squamous cell and basal cell carcinoma. Anybody in this room or group 7 and group 8 agree? Twelve of you. Anybody agree? You have to choose. You don't have a choice, not voting. You have to choose agree or disagree. Anybody agree with this phrase? Oh, show your hands. Show your hands. I will count. Because, okay, 1, 2, 3, 4, 5, 6, 7. 7, right? 7. That means the other 5 of you disagree. Correct? No, you have to make up your mind. You have very, very limited time. Okay, again. We have very limited time here. Who agree with this phrase? Show your hands. 10. Okay, you have a lot of friends. Who disagree? Supposed to be 2. All right, we will see if this proportion change after the 2 groups presenting. All right? Okay, shall start. We will begin at 1:35 and finish at 1:45. Your group will take turn, and then you will have another 5 minutes after them, and another 5, and we will vote again. Are you ready? Okay.
Okay, good afternoon, professor and medical student. Today our team will talk about a disease that's called only 4% of all dermatologic cancer, but it responds for as much as 80% of all deaths from skin cancer. Yes, this is malignant melanoma, the aggressive therapy-resistant malignancy of melanocytes, with incidence increasing worldwide and more public health problem. Exposed to the solar UV radiation, dysplastic Nevi syndrome, and family history, all of this is the major risk factor of this malignant melanoma. And although 95% of this tumor found in skin, melanoma is not exclusive with the skin cancer. The site of primary extracutaneous melanoma includes ocular, mucosa, GI tract, GU, leptomeninges, and lymph node. This makes it really hard to find the primary site. This is because melanocytes originate from neural crest cell. During the early weeks of gestation, melanocyte precursor differentiate and migrate from the neural crest to normal tissue and especially skin.
Now, as for the incidence of melanoma, melanoma accounts for 5% of all skin cancer, but it does account for 3 types of death compared to the non-melanoma skin cancer. Therefore, melanoma seems to be a little bit more malignant than any other malignant tumor. Melanoma, there is a suggestion that each year there is an increase in the incidence of melanoma. That does mean that melanoma is going to be more common. Melanoma tend to be more common in Caucasian people than Asian and Africa. This possibly can be explained by the amount of the melanin each race has. When comparing between both sexes, men has a slightly higher risk to develop a melanoma than women. The melanoma also affects young and middle-aged people, especially people who are younger than 55 years old. In Thailand, there is no clear evidence about the real incidence, but as for the Southeastern Asian, it is estimated that there is 6 male people per million and 5 female people per million will develop this cancer, making it quite rare to have a chance to diagnose it. To summarize, you can see that melanoma is indeed a really malignant tumor. Although it is not rare, it doesn't hesitate to kill. Here is the risk factor of people who have the chance to develop a melanoma. To summarize all of the risk factors, you can see that melanoma depends on the amount of the chronic sun exposure people have and the melanin people have. Yeah. Next.
A total body skin examination is crucial when evaluating a patient with a melanoma. The early signs of melanoma are summarized as pneumonic.
It's not different. She stand or sits.
Different.
Just kidding.
Of course. The early signs of malignant melanoma are summarized as the pneumonic ABCD. A is asymmetry. B, border irregular. C, color more than one, colorful or red, brown, blue. Diameter larger than 6 millimeters. According to this table, the common signs of cutaneous melanoma are head, neck, trunk, and feet.
The staging of this disease is there are many ways to stage, but from the HJCC staging is very popular because it's easy to understand and it can tell prognosis from 5-year survival rate of in every state. The prognostic factor of the melanoma is the thickness or the depth of the lesion and the lymphatic spreading and the ulceration and the one prognostic that not in the criteria for staging is mitotic rate. This just pathology, not clinical. Okay, in stage in stage 0, the tumor confined to the dermis, or you can call carcinoma in situ. In stage 1, the lesion thickness is less than 1 millimeter deep, with ulcer, or more than 1 millimeter deep without ulcer. Stage 2 is 1 to 4 millimeter deep with ulcer, or more than 4 if no ulcer. And the stage 3 defined by lymph node spreading that needs the lymph node biopsy to determine. And the stage 4 is not characterized by the lesion, but it has spread to other organs.
They mentioned this is supposed to be stage 0 in epidermis.
Okay.
Okay.
And you can see that 5-year survival rate, if you can only detect it in stage 1, 5-year survival rate is high, just more than 70%. But if you can detect it in the late stage, 5-year survival rate is very little. Just to stage 4, 5-year survival rate is only 7 to 19%. And the metastatic rate of melanoma is around 30 to 80%, and can metastasize to central nervous system 10 to 40%. The common site of metastasis is brain, lymph node, lung, liver, abdomen, and bone. The most common is lymph node and subcutaneous tissue. The visceral organ, which is most common site, is lung, around 70%. And how do you know it metastasis? There are high risk character of the lesion. Poor prognosis lesion is thicker than 4 millimeters, have ulceration, has lymphatic involvement, and have high mitotic rate. So the investigation you need is biopsy from the lesion and also the sentinel lymph node.
Treatment. If limited disease, resection is recommended. Alternatively, observation or systemic therapy. For patients with unresectable disease without brain metastasis, treatment includes systemic therapy. Patients with brain metastasis require treatment of central nervous disease. Systemic therapy, for example, combine chemotherapy and targeted therapy. The targeted therapy can be used in highly resistant tumor.
Now let me talk about the economic properties. Okay. Oh, sorry.
Maybe you need to look at the monitor.
I will try it. The 2008 cost of care is increased dramatically more than the 1997 because of, as my friend told you before, more incidents and more advanced chemotherapy we use in melanoma means a cost. And 57% of cost is spent on metastatic disease with a very poor prognosis and only 7% survival rate in 5 years. So we spend a half of money in nowhere. And the peak age group in this disease is about 45 to 55 years old, which means a peak productivity. So not only the cost of care, we lost an opportunity cost as well. 57% of the cost is spent on stage 4, as I told you before. And I will try to find a cost effectiveness on screening. One paper showed that is no cost effectiveness in United States or Germany. But one paper proposed only one-time screening, or screening in every 2 years in high-risk group, such as high-risk siblings of patients with melanoma or siblings.
Hello everybody. Welcome to the summary of my team. Malignant melanoma. Although it was once considered uncommon in Thailand, the annual incidence had increased dramatically over the past few decades. Incidence approximate 5 to 7% yearly at a faster rate than that any other tumor except lung cancer. You understand the incidence is very high, but I think the malignant melanoma are more forbidden condition. Next, if the clinician can detect this disease early, you can treat it by surgical excision and the patient will be fine. So, conclusion. A malignant melanoma is a more forbidding condition. Thank you for your attention.
Group 6, you have a very tough job to beat them. Okay, come on, hurry up. Okay, so you make up your mind, Group 7 and Group 8, all right? Don't fall for them. And prepare the question because you have 5 minutes for each of them.
Hi. Good afternoon, everyone. We are in the topic of malignant melanoma is a more forbidding condition than basal cell or squamous cell carcinoma. And we are the group that object the topic. Yeah. Let me give you some information about basal cell and squamous cell carcinoma. These two are called non-melanoma skin cancer. It's the most common type of malignant neoplasm in the world. Incidence of 1 million cases per year. And the basal cell carcinoma is the most common type. And the squamous cell carcinoma have higher mortality rate and have increasing incidence.
And I'm going to talk about basal cell carcinoma. The basal cell carcinoma is the most common form of skin cancer, the most common malignancy in humans, the most frequent periocular malignancy. An estimated 2.8 million are diagnosed annually in the US. And basal cell carcinoma, although it is rarely fatal, less than 0.1% of patient deaths, but I will tell you in the next slide. Okay. The risk factors are the chronic sun exposure, exposure to radiation, fair skin, sex, male more than female, and age 50 or older, a personal or family history of skin cancer, immune suppressing drugs, exposure to arsenic, and inherited syndromes that cause skin cancer, which is rare disease. The common sign of basal cell carcinoma is sun-exposed areas such as face, ears, neck, scalp, shoulders, and back. It is a slow-going lesion that doesn't heal and that bleeds when traumatized, and often start as small pellet pink or fresh color pearly bumps. This is the picture of the basal cell carcinoma. It can look like open sores, red patch, pink growth, shiny bumps, or scars. And can be look like this if it is left untreated. It is rarely metastasized, rarely fatal, but can be locally destructive. It can look like this. A 44-year-old male patient with growing lesion on the right side of face for 10 months. He lived alone on a farm. 2 years ago, his own dog had clawed on the right side of the patient's nose. 11 months ago, he had been injured by a splinter wound in the same area. A gradually growing, ulcerating lesion had developed on his right side of face. The clinical diagnosis was basal cell carcinoma. CT scan revealed an extensive bone defect. Maxillary sinus was ruined. Half of the nasal bone and zygomatic arch was missing. The external wall of the frontal sinus was involved. Multiple biopsies confirmed the presence of basal cell carcinoma. This is the histopathology of the patient. You see the basal cell carcinoma invade through the basement membrane of the skin. Here. And this is the picture of the patient after the surgery. The tumor was resected and was covered with a frontotemporal rotation flap and a latissimus dorsi musculocutaneous free flap. The patient is now tumor-free, but his face has not been reconstructed, like in this picture. And do you still think that basal cell carcinoma is not dangerous? Okay.
Okay, about the treatment of basal cell carcinoma. The goal treatment is complete tumor removal, just like melanoma. I think best possible cosmetic result if you can detect in the early stage. And guideline in 2011 and can be treated at Curatas or in you know that it exists. The prognosis, okay, it look great. It looks okay about it. Excellent prognosis, okay? But it's, although it's rarely metastatic, but 35% develop another tumor in 3 years, and 50% develop another, not a recurrent, basal cell carcinoma in 5 years. Most common recurrent site is in the nose and the nasolabial fold. In 4 to 12 months after treatment. Okay, I will skip this part. It's not.
And I will talk about squamous cell carcinoma. That is, sunlight is thought to be the major risk factor because most squamous cell carcinoma occur on sun-exposed surfaces of the head and neck, and the risk also increases with advancing age, occupational and environmental exposures to ionizing radiation, and cigarette smoking. Most of squamous cell carcinoma begin with actinic keratosis, that is a pre-malignant lesion, proliferation of keratin cells in the basal layer of the epidermis that appear as scaly, reddened, rough lesion. Before local invasion, in situ squamous cell carcinoma lesions are termed as Bowen disease, an erythematous elevated lesion with irregular border. And the last one is invasive squamous cell carcinoma that is present as palpable scaling lesions that become ulcerated centrally, elevated edges, and necrosis tissue.
The treatment option is squamous cell carcinoma have very method most in this size. The prognosis of this tumor, 2 to 5% had metastasis to regional lymph nodes, and in the first 2 years after the surgery to resection of the tumor, have recurrent typical recurrent tumor at that part, and it's more aggressive than before. At one stage, it's called to palliative treatment. Economic burden in study in UK, United Kingdom, have shown that after surgical resection, need to follow up the patient, and the mean cost of post of healthcare over 5 years. That means 100 and sorry, about 1 million baht. Okay.
Finish now? Okay. All right. Please, group 5 in the front. Okay, let's give them. Oh, no, you stay over there because you have to answer the questions. All right, I want you to be presenting both group up front. And now it is the Q&A. All right, before we decide and vote again, any of you have any questions for either group? Right. Any? Okay.
I have a question that that guy in interesting case in basal cell carcinoma, whether he comes in the first visit, he come that way, the first picture. Oh, how many months he developed that picture? 10 months only? Okay, thank you. Thank you.
Anybody want to ask? Okay, pass the microphone.
In your opinion, which one is the easiest one to be detected by the clinician? The both group. I would like to know, in your opinion, is melanoma, basal cell carcinoma, or squamous cell carcinoma, which one is the easiest one to be detected?
I think our non-melanoma cancer is easier to be detected because it is in sun exposed area. But for the melanoma, it is the back or the posterior leg.
For my finding, in Thailand, the common in Thailand the common size of melanoma is palm and so and subangular area, only three size. But in basal cell carcinoma and squamous cell carcinoma, it is common at the sun exposed area like a face, a nose, a neck, or something like that. Yes.
Yes, as I totally agree with them that that it's easy to find, so it's easy to find and detect at first time and easy to cure, which make our disease is more forbidden, right?
But but I want you to imagine the results after the cure. If you think after the results after the cure, the basal cell carcinoma and the squamous cell carcinoma have to leave the scar or keloid on the face, right? So when you see each other, you see this side first, right? It is very bad. Yes. Yes. But if you compare to malignant melanoma, it's common at the palm, the sole. Yes, it's cosmetics. If you walk see with each other people, you don't see the palm first and say it's very bad palm. No, I don't think you will see that.
Okay, I may say something. I agree with you that it's dangerous. It makes non-melanoma skin cancer make the patient have the low quality life, but just cosmetically. But melanoma, it metastasis. No, if people with melanoma, we have to wide resection, and we can have like this picture too. But which would you choose between cosmetically and just metastasis in brain, the liver, in your lung, and the rate is just not so high, just 40.
Okay, but I cannot see your patient in this classroom. Okay, so
So I think in the common sense, it's very rare. So why we know about it? Okay?
Yeah.
Basal cell carcinoma is.
Can I make a little suggestion? Yeah, that it is rare, but it is more common than squamous cell carcinoma and basal cell carcinoma. So yeah, people who have malignant melanoma will not come with the cosmetic problem because he cannot have any more longer problems.
Okay. Let me ask the next question for both of the groups is, you think in the future any of these, melanoma or non-melanoma, can be completely cured first or prevented or eradicated? Which one do you think? Reason why?
Hello. About melanoma, as we been finding all the information we have, it's about the mutation and the genetic, and they are finding ways to treat it as targeted therapy. But it's just the beginning of the study of this new way of treatment, and as we know is from many research, melanoma is resistant to monochemotherapy and not so full great response with combined therapy too.
Okay, about the non-melanoma side, do you think you can prevent this maybe next 10 years completely? I mean, is it possible?
Maybe we cannot completely prevent, but most non-melanoma cancer occur from sun exposure and arsenic exposure. If we can prevent and from that risk factors, we can decrease the incidence maybe.
Yeah. I think both can be prevented, but it depends on the budget, right? For example, in the next 10 years, the gene therapy is so advanced that we can select any child, any children born to our world that if there is one single chromosome that predisposing to melanoma, we just abort all of them, right? This is some of abstract. On the other hand, we cannot prevent sunlight. So this is some kind of tricky question in terms of in the future we may see a role of the chromosome and gene selection higher, and it may be even readily available in 7-Eleven when you go there and swab your mouth and find, oh, you have this abnormal chromosome. Maybe it's time to do the tube ligation at the moment. I don't know. Okay, I think we have a conclusion. Go back to your seats. You made up your mind already? 7th and 8th group? Alright, it's the moment of truth. So we learn something, not everything, but at least you learn how they do a lot of work during the past, I think 10 days, more or less, to come up with the argument. There are no definite answer, as you already know. So before the presentation, 10 of yours voted for melanoma is more formidable, and 2 agree with the non-melanoma. And now I will ask again, who agree? Please raise your hand. Melanoma is more forbidding. condition. 9. This is 9. And who disagree? Why 4? Again, no matter, the non-melanoma group wins, right? Because they change from 2 to 4. But melanoma decrease from 10 to 9. Okay, applause with the non-melanoma group. Yeah. We have a winner. All right, your group 7 and 8. Are you ready? The next topic, okay, group 7, please prepare for the presentation, is pretty much the same interesting level as the first topic. I believe we haven't used this kind of discussion before. It is in order for augmentation, enlargement, or substitute of body organ. Do you think autologous or plastic material is better? The topic is autologous is a superior choice. Anybody agrees? Only group 5 and group 6. Okay. Anybody agrees with the topics that autologous tissue is far superior for body and organ substitute than plastic material? Please raise your hand. Autologous including fat, skin, tendon, nerve, artery, vein, something like that. Okay, anybody show your hands.